Good morning, everyone. I think we should start because we are a bit late and we have to finish before the for the prayers time. It's my pleasure to share this session with my friend Dr. Ayman Smadi, and I would like to thank everyone who attended the Congress and like to thank the organizing committee, particularly Dr. Abir Inab and Dr. Maher Maaita. And I have a small announcement to everyone that at the end of October 30 and 31st will be another Congress at the Royal Hotel for the IRC and in collaboration with the Jordanian Society of OBGYN and the British Society. It will be a general Congress for 2 days. It's my pleasure to introduce the first speaker in this session, Dr. Muna Abulghar. We know her father very well, Dr. Muhammad Abulghar, who was the founder of the MEFS and founder of the IVF in Egypt and in the Middle East. Muna Abulghar is a professor and head of Cairo unit of Fetomaternal unit. She is a professor of OBGYN, and she's going to present to us the topic screening for PIT. Please, Dr.
Thank you so much for the introduction. I want to thank Dr. Abir Annab and Dr. Maher Maaita for their kind invitation. It's a pleasure to be back in Jordan, and I'm very happy to be giving this talk about the screening for preeclampsia. As we all know that preeclampsia is one of the known placenta-mediated pregnancy disorders, which includes preeclampsia, small for gestational age, fetal growth restriction, and stillbirth. And it is a major obstetric complication that results in very high maternal and fetal morbidity and mortality, affecting about 2 to 4% of pregnancy, and therefore could lead to about 70,000 maternal deaths and 500,000 fetal deaths globally per year. And because it's such an important obstetric issue, there were at least 2 WHO recommendations published. The last one was in 2021 about how important it is to diagnose and prevent preeclampsia, that it is a major health problem, and that the major issue with preeclampsia is the resulting or the consequent preterm birth, which of course affects the neonatal outcome. Of course, preeclampsia occurs more in third world countries like Egypt, and therefore it is a problem that we need to address. Why does it occur? It occurs due to a uteroplacental defect, which is the uteroplacental circulation is the circulation which is achieved by modification of the spiral arteries to increase the blood flow and to lower the pressure at the placental surface. This is the normal appearance of the spiral arteries in the non-pregnant state, and this is how they look like in the pregnant. They become very much dilated so as to lower the resistance and increase the blood flow. But in patients with preeclampsia, this is how the vessels look like. They are unable to dilate sufficiently, and therefore this will result in impaired placentations with a high risk of preterm preeclampsia and high uterine artery PI. Trophoblastic invasion occurs as early as 8 weeks and continues till it is done approximately around 14, 16, maximum 18 weeks. And therefore, when this doesn't occur properly, preeclampsia occurs and results in this early onset preeclampsia. So accordingly, what will happen with the uterine artery PI? It will decrease throughout the pregnancy, and biochemical markers such as the PLGF is normally present, and it is low in pregnancies at high risk for preeclampsia. We know that PLGF is a potent angiogenic biochemical, it has a potent angiogenic effect, and therefore if it is lacking or if it is low, it will result in hypoxia. And in these patients, we measure the mean arterial blood pressure, we measure the mean uterine artery, we measure the PLGF, and it is always better to present these parameters in the form of multiples of the median. And you can see it's been published since a long time, and there are several other curves that have been published showing the normal medians of the uterine artery Doppler. It decreases throughout the pregnancy, and in the first trimester you will find that it is high, so the 50th percentile is around 1.6 and the 95th percentile is around 2.5. This is the normal. Then it decreases, so at the mid-trimester, 24 weeks, it's around 1, maximum 1.3, and in the third trimester it decreases even more and becomes less than 1. So this is the normal decline or drop in the PI of the uterine artery PI. We know that we divide preeclampsia into early onset preeclampsia, which occurs before 34 weeks, and late onset more than 34 weeks, and then we have the term preeclampsia, which is after 37 weeks. The FIGO has also addressed this issue of screening and prevention of preeclampsia, that it is an important public health issue, that we should raise awareness, and that there should be universal screening by first trimester combined testing, including risk factors, biochemical markers, mean arterial blood pressure, mean uterine artery PI, and use a calculator to give the patient a risk, or in areas of low resources, we could use the contingent screening with the mean arterial blood pressure, risk factors, and measuring the uterine artery PI. And of course, the recommendation was to give low-dose aspirin from the first trimester till 36 weeks. Other guidelines include the NICE guidelines in UK, and they divided patients into high risk patients of developing preeclampsia, and these patients should have at least one high risk factor or any two moderate risk factors. And the high risk factors, as you all know, include hypertensive disease during a previous pregnancy, chronic renal disease, autoimmune diseases, type 1 or type 2 diabetes, chronic hypertension. The moderate risk factors included that this was her first pregnancy, her age is above 40, the inter-pregnancy interval more than 10 years, the BMI more than 35, family history of preeclampsia, and multiple pregnancies, of course. Accordingly, the patients that were classified as high risk were advised to receive low-dose aspirin, somewhere between 75 and 150 milligrams. The American College had a similar system of dividing patients into high risk or moderate risk with almost the same criteria, and the patients that were classified as high risk were advised to receive a low dose 81 milligrams aspirin starting from 12 weeks till somewhere between 12 and 28 weeks, but preferably before 16 weeks, and I will elaborate more on why 16 weeks is important. The Fetal Medicine Foundation had a different approach, that every individual should have her own risk based on her priori risk, which is dependent on maternal characteristics, her medical history, and various combination of biophysical and biochemical measurements, and that could be different from one pregnancy to the other. When should you do this screening? It should be done in the first trimester from 11 to 13 plus 6. So actually at the same time when we do the first trimester screening for chromosomal abnormalities. And they consider this a one-stop or a one-step procedure. So you put all the data of the patient and all the measurements that you took, and you give her a risk, and the risk calculation is done by special software, which is available at the Fetal Medicine Foundation homepage. Of course, we all know that in the first trimester, we start by screening, measuring the nuchal translucency, checking the nasal bone, checking the tricuspid valve, the ductus, giving a patient a risk for chromosomal abnormality, doing a complete anomaly scan, and screening for preeclampsia. And this is done by measurement of the uterine artery Doppler. It could be done abdominal or vaginal. We obtain a sagittal view of the cervix, and using color Doppler, tilting the probe lateral to the internal os, we find the uterine artery. We put the pulse gate, which should be at around 2 millimeters and the angle less than 30, and we should obtain 3 consecutive similar waves. And we know that this is the uterine artery Doppler when we find that the peak systolic velocity is 60 centimeters or more. And we measure the right and the left uterine artery, and then we take the mean. Then we identify the maternal factors, which includes her age, her weight, her height to calculate the BMI, her ethnicity, the obstetric history, her parity, previous history of preeclampsia, interpregnancy interval, the gestational age and the birth weight of the last pregnancy, method of conception. It does differ in IVF pregnancies versus natural conception, family history of preeclampsia, and of course the medical history that we mentioned before. And all of these factors show increase or make the patient in the high risk group. And then you calculate the risk based on a priori risk, which is her age and her history, the uterine artery Doppler, and the biochemical markers, the PLGF, and the mean arterial blood pressure. And you put this in the calculator. The calculator, of course, has a lot of details about the maternal characteristics, details about her medical history, her obstetric history, dating of the pregnancy, the biophysical measurements, which is her weight and her height, mean arterial blood pressure, and mean uterine artery PI, and finally the biochemical markers, if they are available, the PLGF. And of course, this is a problem. It is very much a financial issue, if it is available or not, if the patients can afford to do it or not, if the labs are available to do these biochemical markers, and if they have the proper multiples of the median to calculate it correctly. Now, according to this, the Fetal Medicine Foundation group published that the detection rate could reach almost 90% if we do this first trimester combined screening, and this performance decreases with the detection of later onset preeclampsia. They proved similarly that you can do it in the second trimester, adding some other biochemical markers, including the SFLT1, and again, the detection rate was excellent. So, the recommendation of the Fetal Medicine Foundation is that you stratify the patients into high-risk patients. So, after you've done this calculation, the patient is classified into a high-risk patient if her risk is more than 1 in 100. And these will represent about 10% of the population, and 75% of them will develop preeclampsia less than 37 weeks. So, this group should be given aspirin. And if the risk is low, repeat the uterine artery Doppler at 20 to 24 weeks. And if we compare the different methods, the NICE guidelines that I mentioned, where they advised if she's high risk to give aspirin, and the American College guidelines, again, they advised to give low-dose aspirin. But if you compare the effectiveness, you will find that the Fetal Medicine Foundation algorithm had a much higher detection rate, especially for the preterm preeclampsia, which is probably the highest risk group because they are born earlier and they have all of those risks of prematurity. Working in a third world country like Egypt, it is very important to try to reach the maximum weeks that could be possible before delivering the baby. And of course, the detection of the NICE guideline is much less than 50% will detect the early onset preeclampsia. Maybe the American College performs better, but with a higher false positive rate. And therefore, the Fetal Medicine Foundation algorithm is probably superior. Now, why is this important? Because now treatment is available, and we know, we have evidence that giving low-dose aspirin will reduce the risk of preeclampsia, will reduce issues such as small for gestational age, stillbirth, and so on. It started with the ASPRIN study, which has now been published 8 years ago. It was a double-blind placebo-controlled study where they divided the patients into 2 groups. There were more than 800 patients in each group. According to the risk calculation, if the patient was at high risk, half of the patients received the 150 milligrams of a low-dose aspirin, and the other half received the placebo. This was done in the first trimester from 11 to 14 weeks up to 36 weeks, and it proved a significant reduction in the rate of early preeclampsia in the patients receiving aspirin, almost a reduction of 60% from 1.3% versus 4.7%. And you can see the odds ratio shows this significant reduction in the risk of preterm preeclampsia. It significantly reduced the incidence of preterm preeclampsia. This was followed by several other studies, a systematic review and a meta-analysis, including more than 18,000 patients in 45 randomized controlled trials. And they showed that if you start aspirin before 16 weeks, there was a significant reduction, which was dose response dependent. And the reduction, the relative risk was 0.57% for preeclampsia, 0.47% for severe preeclampsia, and 0.56% for fetal growth restriction. But if you start after 16 weeks, the reduction is smaller, 0.81 relative risk, and that didn't really have to do with the dosage. It was not associated with a risk reduction or a dose response effect in cases of severe preeclampsia or fetal growth restriction. So definitely if you start earlier, you get the maximum effect, and no effect on the term preeclampsia. Why does it work, and how does it work? We know that in cases with preeclampsia, there is deficient intravascular production of prostacyclin, which is a vasodilator, and excessive production of thromboxane, which is a vasoconstrictor and a stimulant of platelet aggregation. So it was thought that if we give antiplatelet agent, especially low-dose aspirin, this will delay and reduce the incidence of occurrence of preeclampsia. And as I mentioned, it really makes a difference if you started earlier because of the theory of trophoblastic invasion, which I explained in the first slides. But not only a reduction in the risk of preeclampsia, also a reduction in or prevention of perinatal death and adverse perinatal outcome. Again, the Fetal Medicine Foundation group published a meta-analysis including more than 27,000 women. They all started before 16 weeks with a low-dose aspirin, and there was a greater reduction with a relative risk of 0.47 versus 0.78 if you started early before 16 weeks. It had the same effect on severe preeclampsia, fetal growth restriction, preterm birth, and perinatal death. And this was proven by other groups. The same results were achieved starting aspirin before 16 weeks. And finally, a Cochrane review with more than 40,000 patients. When you start aspirin early on, in 1,000 women that received the aspirin, you will be able to have 20 less pregnancies with serious adverse effects, including the preeclampsia, the preterm birth, the small for gestational age, and the fetal and neonatal death. Before the introduction of the first trimester, over two or even 3 decades ago, the mid-trimester uterine artery Doppler was used, and it proved to be effective in expecting a preeclampsia or doing screening for preeclampsia. But of course, after the publications of the low-dose aspirin and the importance of the timing, this of course became of less importance, and the recommendation is to start earlier on measuring the uterine artery Doppler, and that if you combine the uterine artery Doppler in the second trimester together with the maternal factors, this will give you a better prediction of preeclampsia. If you add the Doppler characteristics to the maternal characteristics and measurement of the blood pressure and the BMI, you can identify more of the women that will develop preeclampsia. Similarly, the small for gestational age are better diagnosed if you add the maternal risk factors, the uterine artery PI, and biochemical markers such as the PLGF. And finally, of course, how you measure it, just as you did in the first trimester, you can do trans-abdominal or trans-vaginal sonography, and you, at the crossing of the uterine artery with the iliac vessels, you will get this typical waveform, and this is, of course, a normal waveform, and this is a waveform with a notch. But, of course, studies have shown that it is better to use the indices than just to comment on if there is a notch or not. And finally, in the last 5 years, there have been many publications about continuing further, measuring the uterine artery Doppler in the third trimester to detect preeclampsia and small for gestational age fetuses, because we know that the outcome of these babies becomes much better once we predict that these women are liable to preeclampsia. They get the very good care and the proper management. The outcome is better. Of course, the effect is not as the risk assessment that was done in the first trimester, but it is of value. And the recommendation is that it is better to do it around 36 weeks, better than the 31, 32 weeks, combining the maternal risk factors, the estimated fetal weight, and the uterine artery PI to give this patient a specific risk of developing preeclampsia or adverse outcomes. And thank you very much.
Thank you very much, Professor Abulghar, for this comprehensive lecture. And we have Dr. Malik. Usama or Malik? Okay, Dr. Usama, please.
Thank you very much. A little bit confused about the last publication that you put in 2025 about the 36 week. Did they include uterine arteries?
Yes, yes, they measure the uterine artery in every...
But was it useful at 36 weeks?
Yes, it seems that 36 is better than the 32 weeks. And of course,
asking about
if it was useful or not, yes, but of course less than if you do it earlier on in pregnancy, yes.
Okay, thank you. Dr. Malik?
Thank you. Thank you for amazing. I need to mention something. We have now a new randomized control trial regarding adding pravastatin to the aspirin to prevent preterm preeclampsia. So I added pravastatin to my patients. Now I have good outcome. So what is the role of pravastatin, if you know? And second question, term preeclampsia, despite all negative screening, we have still term preeclampsia.
Yes.
They are uterine artery normal, uterine artery Doppler, but despite all normal screening, we have still term preeclampsia. If you know, do we have another screening for term preeclampsia? Thank you.
I have no experience with the pravastatin, so I'm sorry I cannot answer that part, but I think the term preeclampsia, which is the most recent recommendation by the ISWOG, is to do a third trimester scan for estimation of fetal weight. And I think this is what will sort of guide us that this patient might be at high risk. The estimation of the fetal weight in the third trimester, and of course in these patients it will be small. So I think in addition to the uterine artery Doppler, assessment of the fetal weight in the third trimester seems to be very important.
Professor Mona, do you think it is should not be given routinely if there is no risk factors?
You mean aspirin?
Aspirin.
No, yes, I don't think it should be given routinely. I think we should stratify our patients into high risk and low risk.
There is a lot of practitioners and gynecologists
that give it routine.
Who give it routine. In my opinion, exactly, you agree on it?
Yes.
It should not be given if there is no risk factors.
Yeah, maybe they do this because many of our patients are in the high risk. The BMI is high, and many of them have the history of chronic hypertension or diabetes. Yeah. But I think it should not be given routine, except if she's in the category of high risk.
Okay, thank you very much for this very nice lecture. And Dr. Ayman will present the next speaker.
Thank you.
Thank you very much, Dr. Mazen. Our next speaker is Dr. Lisa Story. She's a senior lecturer at King's College, London, and she's a consultant in obstetric and fetal medicine. She co-authored the UK National Preterm birth guidelines and the RCOG Green Top guidelines on cervical circulage, and she's currently on the RCOG Scientific Advisory Committee for RCOG Green Top guidelines committee, and she will talk about full dilatation, cesarean section, and the risk of preterm delivery.
That's great. So thank you very much. It's really nice to be here, as I said before. And as I alluded to last time I spoke earlier this morning, I'm just going to spend a little bit more time talking about full dilatation cesarean sections and their risks and associations with subsequent preterm birth. So cesarean sections are rising globally, and I think that applies to all regions of the world. So between 1990 and 2014, there was actually an absolute increase in cesarean section rates of about 12.4%. So that's now 1 in 5 women worldwide delivering by cesarean section. But actually within that group, full dilatation cesarean sections are disproportionately affected. So one study from North America found that over a 10-year period, actually the rise in full dilatation cesarean sections was about 44%, which is really significant. So I think it's already really well characterised that second stage cesarean sections are associated with really significant morbidity, and that can be for both the mother and the baby. So from the mother's perspective, acutely, there's a risk of uterine angle extensions, postpartum hemorrhage, and from the baby's perspective, having a full dilatation cesarean section can be extremely traumatic. You know, it's associated with skull fractures, hypoxic ischemic encephalopathy. Why are these rates rising? We don't really know, but I suspect it's a combination of lots of factors. I think training in instrumental deliveries is probably getting worse, certainly in the UK. And also there are cultural factors as well that have at play. You know, patients are making choices when we're counselling them in an acute setting that maybe aren't always the wisest decisions for their long-term health. But as well as those very acute problems with full dilatation cesarean sections, we now know that actually there's an association with subsequent preterm delivery as well. So the first evidence for this really came around about 10 years or so ago. So Levine et al. Undertook a study of about 800 women. And what they found was that where women had had a full dilatation cesarean section, they were more than 5 times more likely to have a subsequent late miscarriage or preterm birth than where that initial cesarean section was performed in the first stage of labour. And actually those findings have subsequently been replicated in much larger data sets. The study from Woolner et al. Was published last year in AJOG, and that had over 300,000 women, and they found exactly the same things. But I think even more worrying than that is that this risk of subsequent preterm birth is more likely to be recurrent. So results from our group, we found that actually where women had had a full dilatation cesarean section, they were far more likely to have multiple recurrent preterm births compared to a woman who'd had her first delivery by a vaginal delivery. And I think when we're looking at these figures, you know, actually the background rate of preterm birth is 8% in the UK. So actually, if you have a term vaginal delivery, your subsequent risk of preterm birth is less than 2%, so it should be protective. But actually, it's not even limited to full dilatation cesarean sections. So this is just a kind of putting some of the data from the Levine paper into graphical format. But you can basically see that the more dilated you are at the time you do that cesarean section, the higher your subsequent risk of preterm birth. So down at 6 centimetres, your risk is reasonably low. But certainly by the time you're getting to 9, 10, it's really disproportionately increasing. And again, we went back to our data in our unit looking at what these women faced in terms of recurrent problems. And again, we're finding that there's a twofold increase of having a recurrent preterm birth. So everything that I've presented so far is the retrospective data about the problem. So really, because we kind of, that's where we started. We then thought about going about the problem prospectively. So we've just finished a study now called CRAFT, which is based at King's, but it actually incorporates 47 sites within the UK. We were basically looking at all women who'd had an emergency caesarean section in their first pregnancy and seeing what happened in their subsequent pregnancies. So recruitment was over a 4-year period. It had a little brief interlude due to COVID. And as well as that high-risk cohort of women who'd had a previous emergency caesarean section, we also had quite a large cohort from 15 sites of 70,000 women or thereabouts who'd had a term vaginal delivery, just so that we could compare their data. And this isn't published data yet, but again, it's very much confirming those findings that we had in the previous slides, that emergency caesarean sections do confer an increased risk of subsequent preterm delivery. So this is just a headline slide, but the reason why the number here is a little bit lower on the previous slide is that we've looked at all emergency caesarean sections for this analysis. So obviously your risk at 4 centimetres isn't going to be as high as your risk at 9 and 10 centimetres, but we will be looking at the data in much more granularity to look at the different cohorts within it. So I guess the next question from all of this really comes about, why is this happening? So I think everyone who practices obstetrics knows that full dilatation caesarean sections can be extremely challenging, and you're always taught to go high. And this is a combination of the fact that when women have been in labour for a long time, the tissue gets quite edematous, but also just thinking about the anatomy, there are changes that are happening too. So the picture on the top right of the screen here is actually from a textbook back from the 1950s. So this is a very well-known phenomenon, but when your uterus is, when the cervix is fully dilated, it's essentially becoming part of the lower segment of the uterus. And actually, sometimes the incision can be inadvertently too low and actually in the cervical tissue. And that's always a balance, particularly when you're sort of more at the start of your clinical training. The immediate problem in front of you is delivering that baby. And if you make your incision too high, then you can't get the baby out. So it's always a balance, and there's no magic line that tells you where to make your incision. But I don't think the problem's just limited to the incision itself. I suspect that uterine angle extensions are probably a large part of this problem as well. If you think of the cervix like an elastic band or a sphincter, if you transect it in the vertical plane, you're actually compromising its integrity and you're weakening it. So it may be just more complex than that initial incision. So when you get these uterine scars, you can see the kind of effects you have. Here we have a picture from a hysterectomy specimen of a woman who'd had a previous caesarean section, and it's formed a niche. I mean, in this particular picture, it probably is just about in the lower segment, but you can imagine if it was just a few millimetres lower, then that's right at the level of your cervical os. And you can actually identify these niches on ultrasound as well. So the picture on the other side there is actually an ultrasound sagittal plane section where there's quite a large niche near the internal os. So again, as I kind of mentioned earlier today, because of all of this evidence that we've now got coming through, actually full dilatation caesarean sections are part of our preterm birth referral pathways, and they sit here in the intermediate pathway. So basically what we recommend now is that anyone who's had a previous full dilatation caesarean section, and actually the national screening programme doesn't include all emergency caesarean sections, as I think that would just overwhelm the system. But it does say that where women have had a previous full dilatation caesarean section, at a minimum we would offer them at least one transcervical length between 18 and 22 weeks. And whether that's done in a preterm clinic or whether it's just done at the time of the anatomy scan is very much up to individual hospitals. So what do we do for them when they come? As I kind of mentioned in the last slide, we do a transcervical length. But this is just quite a crude assessment, really. And yes, we still take the cutoff as less than 25 millimetres if we need to act, but it's probably more complex than this. So the bottom slide is actually from Professor David group at UCL in London, and she's been quite interested in seeing whether you can actually visualize the scar in these women in their subsequent pregnancy. So what she did was she took a group of women who'd had a previous full dilatation cesarean section, and she systematically looked for the site of the uterine scar. And how they actually do that is that they get the uterine arteries at the level of the paracervical tissue, and that's how they define the internal os. And what they then did was tried to visualize the scar, which they managed to do in just over 90% of cases, and then they looked at how many millimeters above or below the os that scar was. And they did actually find that having your scar within 5 millimeters of the os, it didn't matter whether it was above or below, but that conferred an increased risk of subsequent preterm birth. In the grand scheme of things, those numbers are still reasonably small, and they had actually quite a low preterm birth rate in that cohort, but I definitely think it's something to watch in the future. And when they used the scar as a predictor of preterm birth, it was about the area under the curve from the ROC curve was about 0.73. So that's got reasonable predictive power. So you've already identified that this woman has a short cervix following an emergency cesarean section, but the next question comes about, what do you do about it? So again, we went back to our retrospective data set in our unit to really kind of tackle that. So in this study, we basically had two groups of women. So all of the women had had 3 pregnancies. So in the first pregnancy, the women had had a term delivery. One group was a full emergency cesarean section, and the other group was a term vaginal delivery. So all of these women in their second pregnancy had a late miscarriage or a preterm birth, and it was the third pregnancy that we were looking at. So these women all had a cervical cerclage. And what we found was that actually that cervical cerclage was far less effective in preventing delivery before 30 weeks than it was in the control group. So we then looked at that as a separate subgroup analysis in CRAFT as well, and we're essentially very much finding the same thing. And where these women have an ultrasound indicated stitch, what we're finding is that when they have a problem, it tends to be very early. So you're looking at that 24, 30 week kind of group that is the highest incidence of a problem. And it's kind of indicating that these standard treatments that we have are less effective in this cohort. So again, why is this intervention not working as well as it does in other women? Well, again, thinking about the anatomy. So as I talked about earlier, our standard stitches are a vaginal approach. So a McDonald stitch is placed in the piece of cervix that you can see vaginally, whereas a Shirodka is possibly a little bit higher and involves bladder reflection. But here we're saying maybe this area of injury is actually up near the internal os, and that's the kind of danger territory, if you like. And maybe these stitches just aren't getting high enough. So really, because of that, we started thinking about whether actually other approaches may be better, and maybe a transabdominal cerclage may be more suitable for these women. And again, when we went back just initially to look at our data, that's what we were finding from the very small numbers we had in the retrospective analysis. So just a little bit of background about TACs, and I don't know how common you put them in here, but transabdominal stitches are essentially put higher in the uterus, in the cervix, and potentially even in the lower segment of the uterus. So in our unit, we always put 2 stitches in. One is really at the level of the internal os, and the second stitch is just in that lower segment of the uterus. So you can do them either laparoscopically or at laparotomy. Again, we tend to go for the laparotomy purely because Prof. Shannon, who runs the group, feels that you can actually get better tension on the stitch and you can tie it tighter. But certainly the limited data that's out there comparing the laparoscopic versus an open approach shows that they're reasonably compatible in efficacy. And what we do, we use a monofilament stitch. We put the 2 stitches in, and that then stays there forever. So we don't remove them after pregnancy, and we've actually had women who've had multiple pregnancies on the same stitch. We've done hundreds of them now, and we haven't found any problems with fistulas or anything like that. So then the question is, when do you put it in? So ideally pre-pregnancy. but you can put them in before 14 weeks, but that has inherent problems associated with it. Obviously, everything's more prone to bleeding. You've got the risks of the anaesthetic, and potentially if you're putting that stitch higher up, you're actually compromising that pregnancy, or there is the risk of doing that anyway. So who do we use transabdominal cerclages for at the moment? Well, the best evidence again comes from the Maverick study. So that was basically looking at different types of stitches, and it found that really the only women that really benefited from just putting in a transabdominal stitch straight away were women who'd had a previous failed vaginally placed stitch, so either a history or an ultrasound indicated stitch. And it didn't include women who'd had a rescue stitch in that paper. So if anybody's at all interested, we've actually got a video on how to perform transabdominal cerclages as well. That was published in AJOG. And it has both the laparoscopic and an open approach as well, if anyone's interested. So I guess the next question is really, we need some evidence to find out whether you can have a hypothesis, but you want to check it out, you want to rigorously assess it before you start introducing it into clinical practice. And that's what the above study is aiming to do at the moment. So this is a study which has just recently opened in the last year or so, and it has two main aims. So basically, we're trying to evaluate the effectiveness of TACs in comparison with those vaginally placed stitches in women who've had a previous mid-trimester loss or preterm birth following an in-labour caesarean section. And then the second outcome is to compare the pre-pregnancy with the pregnancy TAC. So this is just the flowchart of how we recruit. So to be eligible, women have to have had a previous in-labour caesarean section followed by a mid-trimester pregnancy loss or preterm birth before 30 weeks gestation. And then there are basically two arms to it. So women may present in pregnancy itself, and as long as they're 14 weeks, they can then be either randomised to the TAC or to a vaginally placed stitch. Or if they're not pregnant, then we can basically either do a pre-pregnancy TAC or a vaginal stitch when they get pregnant. And that group is mainly women who are coming back for either a debrief following an adverse event or women who are attending for pre-pregnancy counselling. So as I said, it's a multi-site UK study which is starting shortly. So one other thing I just wanted to mention in relation to that study is this really amazing resource that we have in the UK. It's called the Preterm Birth Clinical Network Database. So now it's supported by the charity Tommy's. But basically all women who are attending preterm birth clinics have the option of giving their consent that we can use their data anonymously. So it enables a couple of things. So one, it enables us to look at outcomes for things that have a relatively low incidence. But we've recently adapted it so that it can randomise for trials like this. And certainly, for example, you know, one study that really needs to be done is when you're looking at peri-viable gestations, you know, 23 to 26 weeks gestation maybe, is vaginal or caesarean section better for outcomes? We don't really know the answer, but this is the kind of study that in the future that we hope that this database will be able to tackle. But I think the other really nice thing about it is not only can we randomise and it facilitates multi-centre studies, but women give consent that we can access their child's records until the age of 16 as well. So it means that we can get long-term data into the health of the child, which isn't really normally possible with standard grant funding, which is usually 3 or 4 years. So again, it's a nice resource to mention. So that was a little bit of a whistle-stop tour, but I think in conclusion, caesarean sections are well known now to confer an increased risk of subsequent late miscarriage or preterm birth. And this is important for many reasons, for counselling, risk stratification. But also, you know, we need to maybe think about how we upskill people in instrumental vaginal delivery again, which I think is a problem certainly in the UK. But what we don't know at the moment is how is the best way to actually effectively manage these women. But again, watch this space for the result of the above study and see how TACs are performing. But thank you very much.
Thank you very much. And before taking short 2 questions, we have an announcement. الصلاة إن شاء الله راح تكون هون بقاعة البتراء بعد إنهاء عند اوكي يا بكفي. طيب عند الاوفيس في البتراء في صلاه بعد ما ننهي من هون ان شاء الله. اذا في كويستشنز دكتوره عبير تفضلي.
Do you think this is recurrent in subsequent pregnancies or just after the first delivery of a previous, cesarean section and fully dilated? And if there is a role for progesterone use or not as prophylaxis? And do you think these patients are liable for uterine rupture if you go for a VBAC?
Yeah, so really good, all really good questions. I'm really sorry, I'll try and remember them all. But so in terms of the progesterone, really good question. I suspect it won't be effective because I think this is a mechanical problem essentially. But again, we are going to look at that data in CRAFT, but the numbers are so small. I'm not sure. But yeah, really interesting question and one that I've wondered about previously. The uterine rupture question is another really good question. So all of these women then subsequently deliver by cesarean section, but we have seen a case where they had a preterm section with a tac in situ and then had a uterine rupture. So I think, you have to watch these women very carefully because if they start to contract, then all of that pressure, just as you imply, is going backwards up to the scar. So yes, I think they need very careful handling. And is the problem recurrent? Yes, I think the data that we're getting out is that, you have a problem and it keeps happening again. However, I think if you have a term cesarean section, then you have a vaginal delivery at term or you have a term cesarean section that is an elective, I think you'll probably be fine. I think it's the one that have a problem, then it goes on to be recurrent.
Thank you.
Okay, our next question from Dr. Mazen and then we will proceed.
Thank you very much, Professor Story. I have one question. If you put cerclage and you have done cesarean section in this pregnancy, will you keep the cerclage, the abdominal cerclage, or you remove it? And for how many pregnancies you can leave it?
Another really good question. So we actually leave it in situ. We always check it. So we check it via ultrasound at about 32 weeks of the pregnancy, just to check that those 2 stitches are still there. Because we have had one case, so it works pretty much most of the time, certainly well over 90%. But we had one case where we could see the stitch had come undone on a 32-week ultrasound, and that woman actually chose to have a vaginal delivery. That doesn't happen commonly, but the other reason for checking it is just so you know how it's still going to be okay for a subsequent pregnancy. And if I'm doing, or Prof. Shannon's doing the section, I will always check it digitally as well, just to make sure that you can rely on it in a future
all
pregnancy.
patients delivered by cesarean?
Yes, they're all delivered by cesarean.
I remember in one of the congresses I attended, if you do the knot posteriorly, you can open posterior colpotomy and remove the suture and leave them deliver it vaginally.
Yeah, I've seen case reports that
Yes.
have recommended that. And I think the theoretical risk of leaving that suture in, particularly if it's monofilament, is whether you form a fistula with the bladder. But we haven't really experienced that at all, I have to say.
Okay, thank you very much.
Professor Abulghar, do you want to ask anything?
So what do? You mentioned in the study that she must have had one preterm birth after this cesarean. What do you do with the cases that are coming with just a previous history of an emergency cesarean or fully dilated? Do you give them special care? And the definition of emergency cesarean, because would it be written in the file in details that she was fully dilated and something happened? Because this would be a problem in our part of the world. We might not have all the details of what happened resulting in this cesarean. Thank you.
Yeah, again, so basically, yes, we're trying to get all of that data. You're right. There are going to be the odd cases here and there that you don't have all of the details of that first cesarean section, but in the study protocol, it's very much been trying to get all of that information. And we do have a lot of the outcome data. I'm really interested in the angle extensions, as I said. I think that's really fascinating. And what do we do at the moment? So yes, we're screening all these women. If they do have a short cervix, we are offering stitch, and we just try and get them as high as we can. So the stitch doesn't fail in everybody, but it seems to fail in quite a high proportion of the women. About 50% is what we're finding.
دكتور فلاح تفضل.
Doing cesarean section with someone who's fully dilated, we have a problem. And doing cesarean section, elective section, without having previous labor pain, we have another problem. And both of them, because we don't have the real anatomy of the cervix. We know that the lower segment is the isthmus, which is the upper 0.5 centimeters in the cervix, and the other part is the cervical cervix proper. If you do cesarean section for someone who's fully dilated, you have to know that we don't know where is the limit of the lower segment from the cervix. And that's why you could be doing it in the cervix itself, in the cervix proper, and not in the lower segment, which is the isthmus, which is the upper 0.5 centimeters of the cervix. And that's why you are dealing with a different anatomy, different pathology, and different different anatomy of the muscular layer of the isthmus from the cervix proper.
Yeah, I completely agree with you. I completely agree.
And if you do it without dilatation, and usually they used to give us, or we used to use 10 and 12 figure dilator cervix dilatation to dilate the cervix prior to closing the cesarean section, so that it will allow a drain from the cervix after elective section without labor. And now they are not doing it. That's why we have leash and retention, and sometimes you have to redo syndrome, we call it, redo and evacuate what collects in the uterus later on if the patient was not fully dilated. So these are something to be taken into consideration when we are dealing with cesarean. Regarding the abdominal cerclage, I have attended some people doing almost every other case abdominal cerclage. I have done probably 3-4 cases of abdominal cerclage. We used to call it Maher Mahran stitch, okay? Because it's related to my late teacher, Maher Mahran from Egypt, okay? And I think if you do a proper Shurudkar suture, you could replace 95% of the abdominal cerclage. Most of the people who do McDonald suture, it is given for the junior doctors, and that's why they do it low down. And the problem is not low down in cervix, it is at the level of the internal os. It is level of internal os. So you have to dissect the bladder until you get a good level of the internal os, then you put your suture. Shurudkar is better than McDonald because it's done by a senior doctor, and usually the McDonald is done by most of the time by junior.
Yeah, I think that's a really good point. So Maverick as well. So Maverick looked at which of the stitches was more effective, and that was a randomized trial. And it did look at operator in it as well. And we certainly see a massive difference in who does the stitch for all of the outcomes. But I think for a small group of women, I think you're right. Like, there is the potential that transabdominal cerclages get overused, but for that small group of women that have had a failed stitch vaginally, they are helpful. And the thing about Maverick was that it was all quite senior people putting those stitches in.
Okay, thank you very much, Professor
That's
Story.
great. Thank you.
May I introduce the next speaker, Professor Rima Beder from Saudi Arabia. She is a professor of pediatric cardiology and fetal medicine. Please, Dr. Professor.
Okay, yeah. Bismillah ar-Rahman ar-Rahim. Again, I'd like to thank the organizing committee, Dr. Abir and Dr. Maher, for this magnificent and conference. I've learned quite a lot, and being a pediatric cardiologist, I'm honored to be among this group. Today we're going to talk about something that I've gained interest in the past 2 years, which is AI in healthcare, and I joined Harvard Medical School for that, and I'd like to share my experience and the value of the AI in the coming era. No disclosures, and AI in healthcare is very important. And just to sum up the talk, we're going to talk about early diagnosis, personalized treatment, operational efficiency, predictive analytics, predictive values, improved patient outcomes. So it's going to make our life easy, yet it needs to be controlled. My vision. So the value of AI in healthcare refers to computer systems capable of performing tasks that usually require human intelligence. So human intelligence is the source behind the artificial intelligence. So we cannot be replaced so far. And it helps us in pattern recognitions, learning, decision-making, natural language understanding. So it will help us. You will have like an assistant, like a secretary that's going to be in your laptop or your computer, and it's going to make life easy for you. Whoever is using ChatGPT now, you know that you have a personal assistant called ChatGPT. AI includes subfields like machine learning, deep learning, and natural language processing. If you study courses in AI, you learn a lot about machine learning, how you sort of train the model. They call it training of the model. So if you want to get a model in cardiology, for example, to read echoes, you have to give the model at least 10,000 pictures of echoes and to teach them that this is normal. Then the machine will be able to understand and pick up the abnormal. So training of the model is very important. Validation of the model is next step. So what we see happening in the market now, with what all the machines that we're seeing, they're trying to put AI to save your time, but not to replace you. So history of AI, in 1950s, Alan Turing proposed the Turing test to measure machine intelligence. So in the US, the military was using AI a long, long time ago, okay? And only recently it has been to the public. 1956, the term artificial intelligence coined by John McCarthy. 1960 to 70, development of early AI programs as the Eliza chatbot. In 1980, AI winter due to funding cuts, rise of expert systems. 1990s to 2000, growth in machine learning, neural networks, and big data. So the learning of the machine, you're teaching the machine, has taken a long time with a lot of adjustments. So now from 2010 to present, we have breakthrough in deep learning applied in AI medicine. I'm putting the references because this is evidence-based talk. Value of AI in healthcare, it will enhance, improve diagnostic accuracy. As we've seen yesterday in the Samsung, when Dr. Haddad was putting the dot on the head circumference, it did give the head circumference a biometric exactly as he did it manually. So this is very important. The accuracy is important. So humans can make mistakes because the training can be different where you put the dot, if I want to measure the size of the heart, where I'm putting the cross section and so on. So they're trying to improve the diagnostic accuracy in the data that you're getting. And early disease detection. Most of the studies have been done on the retina in diabetics because the idea of machine learning is trying to go to the developing countries where the resources are not very good and help them to in medicine, help them to diagnose retinopathy. In Saudi, we have a project also going on, a private project with retina of diabetics and diagnosing them using AI models. And then personalizing treatment. You can have your own chatbot, ChatGPT customized to you. So I'm an obstetrician. I'm going to ask for a program. I'm going to ask for this and that. So it's personalized treatment plans with predictive analysis. If you update your model, if you update the program that you have to update it. So the human beings have the upper hand so far. We don't know the future. Probably they will replace us somehow. Supporting medical imaging interpretation. As we said, the accuracy in the studies that have shown that if you want to diagnose brain tumor, some human beings can miss, but the machine will not miss. It's even more accurate than the human being because you've already trained the machine to read 1,000, 10,000 of normals, and then they can pick up the abnormals. Automating administrative tasks, reducing costs and error. This is what the hospitals are doing nowadays. They're getting a lot of AI in the systems because they want to cut down on the clerks, on the history, on whatever. So this is very important admin-wise, and it's simple to do. Now, example cases in obstetrics, deep learning models measure fetal biometry from ultrasound images. We've seen that yesterday, expert level accuracy. Actually, I've seen it myself, and it was exactly like what an expert like Dr. Haddad did it, and also in the femur length and everything. Also detects fetal anomalies, CNS defects with 97.5%. I mean, if we in the room now, we have a test to measure whatever anomaly, like we will not, like CNS anomaly, whatever is starting from 18 weeks onwards, we are not going to get the 97.5%. Reduction in false negatives, assisting clinician faster. And of course, your time as a clinician is very important. So this is going to save your time. But you are going to be responsible. You are going to sign the form. So it's you at the end, not the model. So this is very important in healthcare industry, what is coming to us now. So these are the references, and that's 2025 that I've used in artificial intelligence in obstetrics and gynecology, advancing precision and personalized care. So this review talks about improving prenatal diagnosis. Of course, if you can get more abnormals with the reading of the machines and so on, and scan efficiency. Sometimes, like if you scan the heart, the lady is obese, the BMI is high, they can help you adjust the image. And ethical consideration in maternal fetal medicine, this is very important. What you let the lady, the patient know and what she should not know. You would not share everything with your patient based on what you know, but based on the legalities of what she can know. So in cardiology, which I'm a fetal cardiologist, and identify congenital heart defects. Now we are models, and we are working with the Fetal Heart Society in the US on validating a model on fetal hearts. So what is the model going to do? We are trying to now validate the model. So we are going to give them 200 images of fetal hearts from every country and then validate the model. This is going to be the first model from the US to detect fetal hearts. As you know, fetal heart is very tough, especially below 16 or 15 weeks. And you have to be a good trainee, and you have to have a good machine, and you have to have the time and patience. So one patient will take 45 minutes to examine the fetal heart. In adult cardiology, AI improves detection of arrhythmias. So now in the clinic, you don't have time, a private clinic, patient comes with chest pain and so on. You forgot to read the ECG properly. You forgot to see atrial fibrillation by mistake. But if the AI reads that, the report will come on your desk before you see the patient. And so this is very, very important. And prevention and treatment, if you want to put them on daily aspirin or daily, so the prescription will go automatically, and the patient, if he is part of the system model, will be monitored as well at home. So these are the references, again, to the AI case models in cardiology, and these are also 2025. And the studies demonstrate AI impact on early diagnosis. Please note that we want early diagnosis. The problem in the developing countries is that the diagnosis comes late, either because the patient is not interested, or they don't have the money, or the government does not have the resources. So this is going to be cheaper, and risk stratification is very important, and fetal and other cardiology critical for improvement of patient outcomes. The outcomes govern everything in health system. You want to decrease the infant mortality rate, you want to decrease the cesarean rate, you want to decrease, as in the morning, the neural tube defects, because if you do surgery antenatally, the cost will go down. As well in heart disease, if you diagnose in utero and transfer in utero, you're going to decrease the rate of preterm labor and unnecessary cesarean and morbidity and mortality and cost to the government and so on. Now, I hope I'm getting your attraction, your interest in the AI in healthcare, and because you are going to be the ones who are using the AI models in the future, very near future. And so, future directions, integration of AI with genomics, personalized medicine. So this is very important. It's all technical. When you are doing or studying the AI in healthcare, there are two groups, the clinicians and the engineers. So we direct the engineers to what we want, and the engineers are the ones who are doing the algorithm and the training. And then we help in the validation. So this is very important. Expansion of telemedicine and remote monitoring. This is very important. You're sitting here and somebody in very far in Jordan, you want to counsel, you want to see the gestation, you want to have a look at the ultrasound, or you want to discuss. So this is like a cheap telemedicine, very cheap telemedicine from clinical data. Emphasis on ethical AI development. Now there are lawsuits going on in the US against AI rules, because AI can make mistakes, but you as a physician, so far, you are legally responsible for that, not the AI. So the question is that lawsuits will go. Yeah, already there are, I think, 2 or 3 lawsuits in the US against AI use in certain categories. Means that the AI said something and what you wrote is different, or the patient outcome was different. There is something that you could be sued from that element. So the summary of this very short talk is that AI has evolved into a transformative tool in healthcare, especially in obstetrics, maternal fetal medicine, and cardiology. So it's a transformation, digital transformation of all our data. It enables clear and more accurate diagnosis. As we said, if you want to do the biometry, the fetal heart, the fetal femurs, the whatever, I'm not sure what other if in pediatrics, you want to diagnose gastroenteritis early, so you want to measure the dehydration and whatever. So it's accurate diagnosis and personalized care plans. I'm going to put the care plan with the help. So I'm not very happy with taking history. I'm not. So when the clinic, you open the AI, you will, and the patient is coming with a whatever in obstetrics as a telemedicine and maternal fetal, she's coming with frequent abortions and losses and so on. So the AI will guide you what questions you have to ask her and documented. So you ask the lady the questions that you might forget, you document your writing, and sometimes there are some programs that you can just talk to the program and they will do the writing. Or they can do the writing for you and you approve it or disapprove it and talk to the AI, say, well, I don't think this point is valid, and so on. The plan, they can also tell you this, she will need ultrasound, she will need CBC, she will need blood tests, they can put the plan for you and you have to check it. If you really depend on AI 100%, I think that will be a mistake, and we might run to that because it's a tool that has to be supervised, I think, closely from the human beings. So the workflows, and then you can see 10 patients in your clinic instead of 4 because you're saving your time. But there's a continued research and ethical implementation. The ethics of AI is very important. And this is going to be one of either limitations or opening doors to the AI in the future. Thank you. I'd like to also invite you to join the fetal series in the YouTube, and we have 40 webinars on fetal cardiology with MFM and fetal cardiologists from all over the world. And it's like a syllabus that we're following. I'm organizing this, and so please use this free information for your sake. And thank you.
Thank you, Professor Rima, for this interesting. I think, as you mentioned, we are going not only in fetal medicine, in all branches of OBGYN. I think I attended the meeting last week, and they were talking about the AI in infertility and even in screening for cancer as well. So I think everyone is going to change the practice in the
If
future.
you want, if you want an AI model, to use an AI in infertility, you have to train the model. You get the model, for example, whatever model you choose in the market, and then you customize. They train the model and you customize it. So you're a fertility consultant, you put what you want from the model. Like your secretary, okay, in the clinic I want this and this and that, check that for me. They would do that.
Okay,
so they're going to go, provided that this field is well tested.
Yeah.
And justified.
Resources for the clinician to apply the AI in his own practice. because it's like CD or it is.
I mean, the companies are selling a lot of AI
But the
programs.
problem is the companies who put or feed the materials in these locations or in the.
You customize it. When you say customize, you educate the model to what you want, and then I mean, the model is already there. So I'm going to teach the model my IVF protocol. So I'm going to give the model the protocols to study.
But
Okay.
the practices differs in different parts of the world. If the
So
one who
whatever
put
you
the
put in the model will give you.
If the guideline, if one put in the AI on a certain protocol, he is from Canada or from UK or from Far East, from Australia. So we always see differences in the materials or in the guidelines, which is a healthy thing.
So if you want to follow the guidelines from ISOC, you feed in the project, the ISOC guidelines. If you want to follow the guidelines from different institution, you feed in the guidelines, and this will be your guidelines.
But don't you think it will
that
be
you follow.
commercial in the future? So the companies who put this AI, for example, the Canadian, and the so enforce us to adopt particular guideline or particular
No.
series.
The company will help you with the model, but you will help you as well with customization of the model. Thank you.
Okay, thank you very much. I think we will break for lunch and for prayers. What time we'll come back? At 2 p.m.